Say them features in your history.
The patient is a postmenopausal woman, ma'am, aged 73 years old, and with obstetric score of P3 and L3, sterilization not done, came came with the chief complaints of mass descending per vaginum for the past 8 months, ma'am. And on there is a history of presenting illness. There is a complaints of initiation of urine micturition, ma'am, and there is an increased frequency.
Micturition.
Micturition.
What?
Initiation of micturition, ma'am.
What do you mean by that?
Straining
to pass urine.
Straining the pass the urine, ma'am. Yeah. And there is also the complaints of increased frequency of micturition, and there is no complaints of any rectal symptoms and signs, ma'am. And on examining the patient, there is a mass, globular pink mass descending from the vaginum of 6 cross 8 centimeter. And the vagina seems to be pale and dry, ma'am, since it is a postmenopausal woman, estrogen deficiency, and rugosity is also absent, ma'am. And there is no ulcerations or anything, but there is a presence of keratinization and with a gaping introitus, ma'am.
Okay, your diagnosis?
The diagnosis is a 58-year-old woman.
58 or 73?
58. 58-year-old woman with P3 and L3, not sterilized, having third degree uterovaginal
prolapse. What did I say? Like, if you tell the obstetric score, you have to tell the mode of delivery.
Okay, ma'am.
Yeah. 58 years.
58-year post-menopausal woman with obstetric score of P3 and L3. Para 3 and live 3. Multiparous woman with 2 normal full-term vaginal delivery with 2 done in home and 1 at hospital near PHC.
Diagnosis, you not tell anything.
Okay, ma'am.
58-year-old postmenopausal, para 3, live 3.
Okay,
all full-term normal deliveries.
Yes, ma'am.
Not sterilized.
Okay, ma'am.
Now with third degree
uterovaginal prolapse with cystocele, ma'am. Came for institutional.
Does she have any comorbidities?
No, ma'am. No comorbidities.
That you must mention.
Okay, ma'am.
So 53-year-old. Tell it again. Diagnosis.
A 58-year-old postmenopausal woman with para 3 and live 3.
Postmenopausal woman, para 3, live 3.
All delivery, normal vaginal delivery with third degree uterovaginal prolapse with cystocele with no other any medical comorbidities, obstetric or
obstetrics empty varo.
Okay, ma'am. Okay, ma'am. Any no other medical comorbidities,
medical or surgical
comorbidities came for institutional evaluation and treatment.
How do you want to manage this patient?
Vaginal hysterectomy with pelvic floor
management means what? Edutone treatment, investigations and then treatment.
Okay.
What investigations will you do?
CBC, CT scan, CBC.
CBC, yeah.
CBC.
Okay. Then
CT. CBC.
What investigations you will do? You know that she's got, it's a surgical case. Pre-op evaluation has to be done. What all investigations will you do?
Urine analysis, urine culture, serology, blood typing, blood grouping. Blood typing, blood grouping.
Blood grouping and typing. Okay, then.
USG.
If you tell blood, you tell of all the blood investigations. What investigations you'll do? Yeah. Keep it on the near to your mouth and then speak loudly so that everyone will hear. You should know CBC because whether she how is her hemoglobin and all. Pre-op anemia, you need to treat anemia and then only take her for surgery. Anything else? You should know. You should.
Serology, VDRL test.
You should know whether she is a diabetic or not. How is her renal function test? What test will you do?
Random blood sugar test.
Blood sugar.
Thyroid function test.
Thyroid function test.
VDRL, HIV test.
All infective screen. HIV, VDRL, HBsAg, HCV, everything you need to do. Then?
RFT, LFT.
Blood urea serum creatinine. Yes. Then
Marcus.
எல்லாம் சொல்லியாச்சு. அப்புறம் ECG, chest X-ray for pre-op evaluation. You'll do all these tests. Okay? Having done all these tests, what next? Hemoglobin is fine. She has no comorbidities. Not a diabetic. Her renal functions are fine. Infective screen ella negative. Thyroids are fine. What next? She is a 58-year-old. Para 3 live 3. All full-term normal deliveries with a 3rd degree UV prolapse. You have done a pre-op evaluation and everything is fine. What next?
She is multipara and so we should older than 40 years, so we should do vaginal hysterectomy, ma'am.
How do you decide upon a treatment for a woman?
Older than 40 years age, ma'am.
Over than 40 years means you do a hysterectomy?
And
if she says, I don't want a hysterectomy, what will you do?
Hysterectomy.
40 is not old. Okay, yeah.
Sling surgeries.
Huh?
Sling surgeries, ma'am. Abdominal slings.
You know, how do you decide upon a treatment for a woman? Or any, like, it depends upon what are the criteria which you will take?
Based on age and based on
based on age.
and based on how many births given.
Based on her obstetric score, or is she willing for fertility?
Yes,
Then anything else based on
Comorbidities.
comorbidities? Yes, very good. Based on anything else?
That's all.
Wishes to retain her menstrual function, like not for this woman, but any other woman.
After retained childbearings.
And her wishes.
Her wishes.
Some women will not part with her uterus. Some women will say take it out. So it's not you who you are going to decide. It will be decided by the patient.
Okay.
So based on these criteria, what did the patient say? Age is 58.
Age is 58.
She has completed her family.
She
She is a postmenopausal woman.
Yes, ma'am.
No other comorbidities which would hinder her treatment process. Right?
Yes, ma'am.
What did you ask to the woman? What did she say? Her wishes.
If she wants to retain her uterus or not, we have to ask the patient, ma'am. If she wants to
What
retain...
did you ask to the patient? When you come here, you have to come
Whether
with an
surgery
answer.
is okay or not.
Huh?
Surgery is okay or not, ma'am.
Yeah, okay, no, for her. What is her wish?
If she wants to retain her uterus or...
What is her wish? What did you ask her? You took the history, no?
Yes,
So she doesn't, she's completed her family wishes, and she's postmenopausal. Correct?
Yes,
No medical comorbidity. So she's fit for surgery. Her wish is what? To remove or not to remove?
To remove the uterus.
To remove. She has given consent for removal of the uterus. Can we do, what will you do next then?
Prerequisites for vaginal hysterectomy.
Yeah.
A pre-anesthetic checkup we should do, ma'am.
Yeah.
And then we should prepare the patient for the OT, and then shifting to the OT.
Yeah.
And then we should...
Okay, pre-anesthetic workup done. What all pre-anesthetic workup we have done now? Everything is fine. X-ray, ECG. Why do you take ECG?
Because any cardiac comorbidities, if
What comorbidities you can find by ECG?
cardiomyopathies,
Only
tachycardia,
Rhythm
rhythms
abnormalities.
are
No
tachycardia.
structural. Structural, if you want, you want to go for a
echo.
echo. Yeah. Then.
And then we can post elective surgery for vaginal
Elective
hysterectomy.
list.
And then...
Is vaginal hysterectomy a treatment for prolapse uterus?
yes, ma'am. It is a curative treatment because...
Is vaginal hysterectomy? Think twice.
No, ma'am. If it is not only the treatment for prolapse of uterus,
Okay.
it is one of the choices, ma'am.
No, no. Is vaginal hysterectomy treatment for prolapse?
Yes, ma'am.
Is vaginal hysterectomy treatment for prolapse? Yes. Yes. Is vaginal hysterectomy treatment for prolapse uterus? No. Then what should be the answer? Huh? Pessaria, sling, no. No. Yeah, site-specific pelvic floor repair. So, if you design, what is POP?
Then come
Prolapse of
Pelvic
Pelvic
organ,
organ
prolapse.
prolapse.
Why does prolapse occur?
due to the weakness of the pelvic diaphragm or levator ani muscles, ma'am.
Okay.
Muscle.
What are the causes for prolapse?
Prolapse.
trauma, congenital and weakness of the supports and
Ma'am, it is acquired and congenital, ma'am.
Acquired congenital.
Congenital. Acquired, it is mostly acquired during the mismanaged childbirth, ma'am.
Childbirth. What are the causes for, what are the problems that occurred during childbirth?
In first stage of labor, there is a premature bearing down, ma'am.
Premature bearing down, it stretches all the ligaments and then weakens. Yeah.
Multiple gestation, ma'am.
Okay.
Big baby.
Big baby.
Big baby. Multiparity. Multiple parity. Big baby. In
repeated pregnancies only. So that will damage
interspacing
the pelvic nerves and that causes weakness.
In second stage of labor, there will be a prolonged labor, ma'am.
Second stage.
And applying of pressure on the fundus to deliver the baby, ma'am. And there is also use of instrumental delivery.
Okay.
And perineal repair is perineal tear also causes not perineal tear. If it is not repaired properly, there is a case. There will be chance of getting prolapse in the older ages, ma'am.
Okay. Anything else?
And then in the third stage of labor, if we do a Crete method of placental delivery, it brings out the uterus, ma'am.
So that is one thing. So what method of placental delivery you ought to be doing?
Controlled traction and contraction method, ma'am.
Controlled contraction. What is that method called? Brand Andrews. Very good. Yes. Then what else causes?
And then these are aggravated by increased intra-abdominal pressure, such as chronic cough and COPD conditions, and strenuous exercises, weightlifting, and obesity, ascites, and everything, ma'am. And in congenital cause of prolapse,
and immediately getting into work. All these Indian women,
early resumption of work after delivery, it is also one of the cause, ma'am. Yeah. And then if the patient is a young patient, it is an nulliparous woman, we can suspect familial similar symptoms, ma'am. It may include Ehlers-Danlos syndrome or collagen deficient syndrome, or spina bifida may also be present, ma'am.
Okay, these are the causes. So you know that the criteria for treatment of a woman is based on the age, the obstetric score, presence or absence of comorbidities, wishes of the patient, and her desire to retain the uterus or to retain the uterus for menstrual function. In the patient, all are there. Positive score, no medical or surgical comorbidities. She's completed her family, she's postmenopausal, and she's ready, fit for
yes, ma'am.
And my question is, vaginal hysterectomy is not the treatment for prolapse, because only if you remove the uterus, she's going to come back with
enterocele and vault prolapse, ma'am.
So you have to do a site
McCaldy coldoplasty we can also do, ma'am, and also we can
so can you just tell me about the supports of the uterus?
Supports of the uterus include fibromuscular and muscular supports, ma'am. Muscular supports includes pelvic.
You can answer.
Uterosacral and caudal ligaments.
Supports of the uterus.
Yes, yeah. Uterosacral and caudal ligaments which supports the vagina and cervix. Pelvic fascia and prolapse.
Paracolpus.
Paracolpus.
Pelvic fascia and the paracolpus. Yes.
Paracolpus which connects the vagina to the white line of the pelvic wall. Yes.
Yeah.
And
so whatever you said, the uterosacral and the mecondrals will be Delancey
support.
Support 1. Yes, support 1. Okay.
Another one is Delancey support 2.
2. What is support 2?
Pelvic fascia
and the paracolpus. What is colpus? What is colpus?
Uterus.
What is colpus? What is paracolpus? Don't mug. You're going to see. Okay. Then that is level 2. What is level 3?
Perineal
body which covers the lower one third of the
muscles and all the lower fascia. So if there is a defect in level 1 Delancey support, what happens? The patient will be having
level 1.
What is level 1 support?
Caudal ligaments and
uterosacral. And it suppose where does it get attached?
To the vagina and cervix.
At the level of?
Cervix and vaginal wall.
Cervix at the level when the vagina opposes the uterus, and the upper part of the cervix and the lower isthmus. And it takes care of the upper vaginal fornix also. So if there is a defect in uterosacral and cardinal ligaments, what happens? The patient will have uterine descent because it's not pulling the uterus, and together with that, an enterocele posteriorly. Okay. Level 2 support defect causes
Cystocele and rectocele.
cystocele because it covers the vagina, pelvic, endopelvic fascia and the paracarpus. Cystocele and rectocele comes because level 2 support is deficient. If there is level 3 support problem, what the patient has? It is in the lower part of the genital region. So liver triani muscles and all that thing. So big genital hiatus, urethrocoele and all this, deficient perineum, all those things occurs. So in the patient, upon examination, you said it was 6 into 8 centimeters, 8 centimeters cystocele was there. And why did you tell it is a pelvic organ prolapse? What made you to think that it is a pelvic organ prolapse? I would say like it is not a pelvic organ prolapse. Justify.
Ma'am, because it is a postmenopausal woman with all the risk factors containing multiparity.
Postmenopausal might not have a pelvic organ prolapse also.
Multiparity.
No, upon examination, what made you to think and say that it is a pelvic organ prolapse?
On examination, we can see there is a globular mass descending by the vagina, ma'am.
I can tell it is a fibroid polyp.
It
has
has
a globular mass.
It has a introitus, ma'am, gaping introitus, so it can
Introitus, Mariana, fibroid polyp also comes. How do you justify your diagnosis?
According to POPQ standard quantification
No,
system.
no. POPQ is only for prolapse.
Okay.
I'm telling it's a
Sound,
fibroid
ma'am.
polyp.
We can
It is
insert
coming out through the introitus. Justify and tell that it is prolapse only and it's not a fibroid polyp.
We can insert the sound inside the uterus, ma'am, and
So,
then we can
in
can
polyp
visualize.
you can't. Huh?
In polyp,
You can. So how will you identify a polyp versus a prolapse?
In polyp, we can see there is a pedicle attached to the inner walls of the pelvis, ma'am.
Inner wall of the pelvis or
Or
the uterus or the
inner walls
cervix?
of the inner wall of the cervix.
If
Cervical
it
polyp.
arises from the cervix,
Cervix.
it can be a pedunculated polyp or
Polyp.
a sessile also. So, other words, when you put in a speculum and see, you're supposed to do a speculum examination, not a pelvic bimanual pelvic examination. You can see the cervical lip. It will be inside the vagina. Then there will be a cervical loss. You can put in a sound hole or so, whatever. Then you can see a peduncle and a polyp. And the uterus is not descended down.
Yes,
What is the level of the cervix? What level the cervix will be? At the level of the ischial spine. Yeah, it will be there inside the vagina. So if it's a prolapse, how did you identify it?
Descending of the cervix.
Cervix is outside the vulval outlet.
Outside
you
the
were
vulval.
able to see with the cervical
Cervix.
mass. Then
Out of the introitus.
it's outside the introitus. It
Introitus.
depends upon the degree of prolapse. 1, 2, 3. Yes. Then you can see the anterior vaginal wall, posterior vaginal wall. You can see the rugae. There is a cystocele. What are the different sulci in the anterior vaginal wall? To categorize and then tell it is only in the anterior vaginal wall, the bladder is there. What are the different sulci? If you see a prolapse, you can see 3 sulci in the anterior vaginal wall. What are the 3 sulci? Just above the urethral meatus, you can see a submeatal sulcus. Then the transverse sulcus. Then the bladder sulcus. What does the 3 indicate?
Position of
What does the 3 indicate? The bladder sulcus is the point of attachment of the bladder with the level, till what level it is there.
If
Transverse is between the urethra and the bladder. Submeatal is just above the meatus. So when you take the prolapse, it is all upturned down. Yes, ma'am. Yes, ma'am. Yes, ma'am. Thank you, ma'am. Thank you. The prolapse is down. But if you take the uterus up, the urethra will be down, then urethra and the bladder, the sulcus will be up, then the bladder, uppermost part of the bladder. If you just imagine it in an ulta way, then it will be like this now. 3 sulcus. So you can identify the 3 sulcus, the vaginal rugosity and the cervix. Suppose if I say it is not prolapse, if it's a chronic inversion of uterus, How do you identify and then? So I'm just going into the DDs of prolapse, just to...
On palpation of the abdomen, we can't palpate the fundus of the uterus, ma'am.
If it's an enlarged uterus, you can palpate the fundus. Always, uterus is a pelvic organ. Normal size uterus, you cannot palpate above the pubic symphysis.
In chronic inversion of...
Chronic inversion of it, if it's a normal size uterus,
we can't palpate the
even
fundus.
in a normal uterus, you can't palpate the fundus of the uterus.
Okay.
Then how do you differentiate
we
between a
can't
chronic inversion and a prolapse uterus?
Sound we can't insert into the
What happens in inversion of uterus? The uterus
the leading
comes
point
down
will be fundus.
and the interior of the uterus is outside. Right? You don't have a cavity. The cavity has come out. So if you what happens to the cervix?
Goes up.
Goes up. So whatever you see outside the vulval outlet is the fundus of the uterus, which is everted. So when you pass a sound, it can look like a polyp also. If you pass a sound inside, you can't. So you can't pass a uterine sound inside, but in case of prolapse, you can pass a uterine sound. So that is one test which you, and if you do an ultrasound scan, what happens? You can find that the fundus of the uterus is missing in the abdomen, and only the adnexal structures, that the tubes and the ovaries are visible on ultrasound in the patients with chronic prolapse. Okay, but with prolapse uterus you can find out, but if it's totally outside, you can't. Okay, you can replace the prolapse uterus, and if you keep a plug and then do an ultrasound, you can see the uterus, the fundus, the contour, the adnexal structures, everything you can find. Yeah. Okay. What are the other DDs of prolapse?
Isolated cystocele, isolated rectocele.
Okay. Anything else? Vaginal wall cyst, urethrocoele, which is Gardner's cyst. What is Gardner's cyst, by the way?
Cyst that appears in the anterior vaginal wall, ma'am.
It can be a vaginal wall cyst also. Why do you say it is Gardner's cyst?
Because it is irreducible, and...
How do you differentiate? What is Gardner's cyst? Okay, read. So the DDs for prolapse will be vaginal wall cyst, Gardner's cyst, a urethrocoele, chronic inversion of uterus, a fibroid polyp. Yeah, and you must be able to differentiate between what is what. Okay. So coming to the degrees of prolapse, what degree of prolapse is your case?
Third degree.
Why do you say it is third degree?
Because we cannot get above the fundus in the fundus.
So what is that? How do you do that test?
We should palpate the mass with fingers placing, ma'am.
How do you do in hydrocele and all, no, in surgery? Get above the swelling in hydrocele. Like that, if you palpate the pelvic organ prolapse and you're able to feel the fundus, get above, the whole uterus has come out of the introitus. It means that it is procedentia. If you're not able to get above the swelling, then it is called third degree prolapse. Okay? So if you're able to get above the swelling, it is called procedentia. If, ma'am? If you're able to get above the swelling, it is procedentia. But if you're not able to get above, you're able to feel the fundus, it is third degree. Okay? So your case is third degree UV prolapse with cystocele and rectocele.
No rectocele.
No rectocele. So when you said in the history, she's a 53-year-old woman with mass descending PV for 8 months.
Yes, ma'am.
Right? And you did tell about what are the histories you will ask for a woman with POP.
We'll ask about any urinary complaints.
So what are the structures which the uterus, when it descends, brings out with it?
Bladder.
The anteriorly the bladder and the posteriorly the rectum. So those symptoms you need to ask. So urinary symptoms, what will you ask?
Initiation of micturition.
What initiation? Why are you telling that? Chumma tappa tappa. Everyone will initiate micturition, right?
Okay,
what
ma'am.
do you mean by
Urinary incontinence.
She's finding it difficult to initiate urine.
Difficulty
in urination, not initiation. That's a wrong term.
Okay, ma'am.
Right? So why she has difficulty in initiation of urination?
Because
you know that the angle of bladder neck angle is altered, right?
Yes, ma'am.
If it has to be up, the whole urinary bladder has come down. That's it. So the whole bladder has come out of the introitus, no. So the bladder angle is not, it's not high up. How does micturition start? There must be intention to pass urine. Then all the nerve supply will not do. The increase in intra-abdominal pressure, it's going to get transmitted to the detrusor muscle, and the internal sphincter opens and she's going to urinate. What happens with a patient with woman with prolapse? The urinary bladder is everything down, right? The bladder neck angle is high. If she strains to pass urine, what happens? The urine goes and ends up in the pouch which is below the introitus, right? The more she strains, the more she wouldn't urinate because it's going to go down, down, down then. So only when, so many patients would come and tell to urinate, they will digitate, replace the prolapse so that the bladder neck angle is maintained, then she'll pass urine. So it becomes a normal thing, no? She wouldn't go to a doctor. She will herself digitate, pass urine and then leave it because the angle is altered. So that is one thing, difficulty in initiation or straining to pass urine. So the more she strains, she wouldn't pass urine at all. That is one thing. Then
increased urgency and frequency of
urgency, frequency. Any one thing which history you missed is you should ask about SUI.
Stress
Urinary incontinence. What is stress urinary incontinence?
It is involuntary passage of urine when on increased abdominal pressure, such as coughing or laughing or sneezing, ma'am.
So, what causes stress urinary incontinence?
Prolapse. It's symptom of prolapse.
What causes stress urinary incontinence? Due to?
Urethrovesical junction descent.
Due to? There is weakness of the mid-urethral sphincter. So what happens? It won't hold, no? It won't hold the urine at the neck. So what happens when there is increase in intra-abdominal pressure? It won't. The sphincter mechanisms don't work. So they leak. If she coughs, she will leak. Or if she sneezes, she will leak. Okay? That is stress. Any stress will cause that woman to leak, and it is a social stigma. No? She wouldn't go outside. She wouldn't drink water. So with strain and descent of pelvic organ prolapse, there is a chance that these women can develop SUI also. Your history should focus on that. You should ask after digitation or after replacing with full bladder, is she able to have good continence? Good continence. So if she has good continence, then you can tell that she has no SUI. Why this is very important? What happens? The prolapse patient has a bladder which is down outside the introitus. If you do a surgery and correct it and push the bladder up, she's going to have an pelvic position of the bladder. After surgery, if woman will complain, if she has genuine stress urinary incontinence, she'll come and asking you, before I was fine, now I'm not able to control the urine. Even if I sneeze or cough or increase in pressure, I'm not able to hold my bladder. It's because of your faulty surgery, I'm having this incontinence. So she'll sue you in the court of law. So if you find out like she has SUI before itself, you can tell it's not because of the surgery. We are correcting and making it to be in a normal pelvic position. The bladder neck integrity is that problem. You have to do additional procedures, then you're safe. If you don't identify stress urinary incontinence before itself and do a surgery, then you'll get caught. So what is the test to find out stress urinary incontinence?
Bonus test, ma'am.
Yeah, how do you do that test?
We should elevate the urethral bladder, ma'am.
So you should reposition the prolapse.
And then repositioning the prolapse. If
and tell the patient to be with full bladder. Only with full urine you can tell. Ask the patient to strain. Right? Yeah.
If there is if the patient has a normal passage of urine, we can say there is no stress urinary incontinence.
No. How do you test stress urinary incontinence?
We should put the patient on the lithotomy position, ma'am, and then we should ask the patient to cough or sneeze. And if there is any leakage of urine along the thighs, we can say that it is a stress urinary incontinence.
So what additional procedures you will do while doing a prolapse surgery to this woman with SUI?
Pessary insertion. Pessary insertion.
No. What surgery? What additional surgery to correct SUI? You know that the problem is the sphincter, internal sphincter. You
Anterior
need to strengthen
colporaphy.
that. So there are tapes called mid-urethral tapes. You have to put that in addition to your Ward-Mayer's vaginal hysterectomy with site-specific repair, all those. So they are called TOT tapes or TVT tapes, trans-obturator tapes, TOT, or TVT tapes, which is from the pubic symphysis. So commonly done is TOT tapes. They fall in the mid-urethral area and they'll maintain continence for these women in addition to your Ward-Mayer's hysterectomy with site-specific repair. And how do you do the test is reposition the prolapse with full bladder. You ask the patient to strain, or before that what do? You know that the problem is in the urethra mid. So you take both your index and middle finger on either side of the urethra. Keep your hand and then press against the pubic symphysis, pubic angle. Then it acts as a sling-like, and ask the patient to cough. She doesn't leak, then she will be benefited by a tape. And then leave your finger, tell the patient to cough, it leaks, then she's having to identify stress urinary incontinence is without the finger. To say whether she will be benefited by a taping is the finger, right? You can directly observe that she has a leak, and then you can counsel her for TOT in addition to your Ward-Mayer's vaginal hysterectomy with site-specific repair. Yeah, there. So you found, these are the histories. When rectal symptoms, what will we ask?
Recurrence and previous surgery history, ma'am, prolapse surgery history.
No, it's for your patient. Don't assume anything. If she has, your patient has nothing, right? She's got a prolapse, which is 8 months duration. And with, if she has rectal symptoms,
Constipation.
Constipation. Why constipation? All the fecal matter will come into the pouch, rectocele, and stay. So they will digitate. Put their hand inside in the vagina and then digitate. Put it posteriorly so that they'll strain and then pass motion. So straining to pass, straining to defecate, or constipation, all these digitating, all these things you must ask. Anything else? What are the other symptoms that these prolapse patients will have? It's a mass which is outside the vulval outlet.
Inconvenience in walking.
So it will be difficulty in walking. She'll have some ulcerations, itching, and then because of that there'll be ulcers, bleeding PV, all those ulcers which is developing, all those difficulty in walking. And if she's a young woman, coital difficulties because of organ is prolapsing, she'll have. So all those symptoms you must ask. Just because you're postmenopausal, we haven't. So suppose, what are the secondary changes that can occur in a prolapse?
Abdominal pressure.
There may be it may lead to carcinoma, ma'am.
Where?
Cervical carcinoma.
No, secondary changes because of prolapse. De novo cancer can occur in any woman because of prolapse. What are the secondary changes that can occur? Decubitus ulcer, because it is lying outside the vulval outlet. What is decubitus ulcer?
It is ulceration due to venous congestion.
Venous stasis.
And friction. And circulatory changes.
Okay. I will tell that that ulcer is cancerous. How will you differentiate?
By biopsy.
Biopsy and?
Via and non-healing ulcer, ma'am.
Cancerous ulcers are non-healing,
ulcer.
Punched out edges, as you see in surgery.
Growth will be present.
Yeah, growth may or may not. But if you take a biopsy, you can prove it. By packing, these ulcers heal. But those ulcers, cancerous ulcers, won't heal. That is the DD. Okay? That is one thing. And pigmentation also can occur. That is one of the secondary changes. Okay? So, so you have discussed everything, all the DDs. You know why did prolapse occur for this woman? What's a etiology that you can put for this woman? Weakness. For your case? Weakness in the... Yeah? History எடுத்தீங்கல்ல அதனால என்ன etiology போட போறீங்க?
Weakness in the supposed of uterus.
Acquired etiology, ma'am.
What?
Of multiparity.
Yeah. Multiparous, big babies, huh?
No big babies, ma'am.
Okay, multiparous, home deliveries, huh?
Yes, ma'am.
So home delivery. So what would untrained dyes would have done for these women? They wouldn't have had a structured delivery, like as you put a partogram, structured delivery wouldn't have happened. Endlessly, they would have asked the patient to strain Mukkamma, all those things. And before full cervical dilatation, they would have asked the patient to strain, which would weaken. And the control contraction wouldn't have been done for these women for placental deliveries, all those things. That is one thing. And the patients would have gone to resume their work immediately in the postpartum period, lifting heavy weights, chronic offline.
Of early resumption of work.
Early resumption of work, all those things. Yes. And another thing you can add on is she is postmenopausal.
Postmenopausal estrogen
loss.
deficiency.
So all these could have caused prolapse in this woman. Predisposition factors. Okay. Yes. So when you start treating, when you want to do a surgery for these women, you said you will take all these criteria, that is age, the obstetric score, wishes for fertility, presence or absence of comorbidities, and the patient's wishes. After taking all this, your aim of surgery should be what?
To relieve the symptoms.
Symptom relief, yes.
To put the prolapsed organ into its normal position.
Okay, so to restore anatomy. Restore anatomy, yes.
And to prevent further prolapse.
So to prevent recurrence.
Recurrence.
Yes, then? Yes, so your aim should be to relieve the symptoms, to restore the anatomy and prevent recurrence. Okay. So suppose restore the anatomy for this woman, what you're going to do?
Vaginal hysterectomy.
It never say vaginal hysterectomy is a treatment of choice for prolapse. Take it today. They'll sue. They wouldn't accept it. Vaginal hysterectomy is not the treatment for prolapse. Pelvic organs have come out. The bladder also has come, some enteroceal. And before that, how did you check that this patient has only uterovaginal prolapse? Uterovaginal means the uterus with the vagina, anterior and posterior. And she has a mild cystocele, a moderate cystocele, and no rectocele. How did you examine?
There is a visible bulge in the anterior vaginal wall when the patient coughs, ma'am. And there is a symptoms of urinary complaints, whereas the patient does not have rectal complaints, and there is no bulge on the posterior vaginal
So you are supposed to do a speculum examination, not a bimanual examination in the exam. But with speculum examination, you saw the posterior part and there was not a bulge when she strains.
Yes, ma'am.
How did you know that she didn't have an enteroceal, the apical compartment, Delancey level 1 support defect?
For that, we should put the patient in the Sims position.
What is Sims position?
With right leg and knees flexed and left.
In lateral position.
Left lateral position. The patient should be lying in the left lateral position. And then right leg
flexed.
Right leg, hip and knee flexed.
Left leg extended.
Left leg extended. Then?
And then we should, by using the Sims speculum, we should
put it in the posterior fornix and then catch the posterior lip of the cervix. Okay. And then see what?
And then with Casco speculum.
Cascos, Sims. Cascos is a self-retaining speculum. Okay, Sims is you have to catch. It's only 2 blades. Okay, yeah.
We should ask the patient to cough or
cough. We have to ask the patient to strain. Yes. And then the same right hand catching the posterior lip of the cervix and diverting, and slowly withdraw the Sims speculum from the posterior fornix.
Okay. Anterior bulge indicates enterocele. Apical bulge.
The bulge which is appearing anteriorly at the posterior fornix will be the enterocele, and the bulge which is occurring in the lower 2/3 is the rectocele. Hope you understood. Okay, that is testing for enterocele and the posterior vaginal defect. Okay, how will you test for perineal body and the gentle hiatus? That and all you are supposed to do. If it's a widened hiatus or a perineal body is not sufficient, how do you test?
By IR spatula, we should measure the
length. Perineal gentle hiatus from the clitoris to the posterior fourchette. And what is perineal body?
Perineal body is between the
from the posterior fourchette to the anal verge. That part between the posterior fourchette and the anal verge. That's the gentle perineal body. How it is? 1 centimeter is very less. At least 3 or 3.54 should be fine. So that you must measure. Measure. Anything else in examination for a prolapse patient you must do in the examination? Not only the pelvis, right? Abdominal examination, what all will you check?
Diverticulation of rectus.
Recti, the weak anterior abdominal wall. Yeah. And how will you check that? Not divarication. The abdominal wall is good or not.
We should put the patient in the supine position.
Yeah.
And then we should ask the patient to lift neck and spine. And then we should
head up all a straight leg raising test to
Raise.
find out whether the anterior abdominal wall tone is fine or not. Why you are supposed to look for the tone?
because if there is more risk of prolapse in
No.
hernia.
No. Why do you want to look? Suppose if this woman is a young woman with a prolapse, young woman around 28, she's got only one kid. You're not going to do a radical procedure by removing the uterus because she would like to have another child or she'd like to have her uterus for menstrual function.
We can use it for pudendal sling surgeries.
Yeah, you're going to take a biological, you want to do a biological sling, you will harvest the anterior rectus sheath. So for that you should know the abdominal muscle tone. If it's weak, no point in taking a biological sling. It's going to fail. So you have to look into the muscle tone so that indirectly indicates the fascia, everything is fine. And you have to examine the RS system, whether she has any chronic cough or COPD. That's going to put her back after a surgery with a wall prolapse. So that has to be treated. Otherwise she'll come with a wall prolapse. Okay. So all these examinations you have done and taken. What anatomical repair we were taking? No, you decided for a surgery. Your aim of surgery is to alleviate patient symptoms, restore anatomy and prevent recurrence. What are you going to do for that?
For recurrence, ma'am.
All three.
To relieve the symptoms, we can do since this patient is a postmenopausal woman, I've completed
So she's given consent for hysterectomy and the surgery. What will you do now?
We can do void smear operation, ma'am.
What Mayo?
Void Mayo. Vaginal hysterectomy with anterior colporrhaphy and posterior colpoperineuraphy.
Yeah.
And then to prevent the wall prolapse, we can attach the wall to the uterosacral ligament suspension. And also we can use mesh.
Okay, mesh. Now we're not doing. Then.
And then we can to prevent enterocele, we can use mechaltoplasty.
Mechalscaldoplasty. What is mechalscaldoplasty?
It is uterosacral ligament is united, and then the anterior pouch of Douglas is obliterated by
So you obliterate, you know that the intestines are going to enter into the pouch of Douglas and come out. If you take the uterus, what happens? The vault is free. The posterior pouch of Douglas is also open. If you obliterate the pouch of Douglas, the intestines are not going to come and press on the vault and the wall prolapse is not going to occur. So there are two types of caldoplasties, vaginal and abdominal. Mechalscaldoplasty is done, you can do it vaginally during a surgery. If you want to do it abdominally, it's called Moskowitz. So you take a purse string suture on the POD and close it. So you're obliterating the pouch of Douglas. So the intestines won't come out. Okay? Yeah, you have done that. You have done a cystocele repair and a rectocele repair. And you can done a
to prevent recurrence.
Vault is closed. What are the complications of surgery you will expect?
UTI. UTI.
So how can you classify complications?
Urinary tract infection.
Short term and long term. And intraoperative.
Intraoperative. Anesthetic complications.
Yes, you can start with anesthetic complications.
And then circulatory hemorrhage.
So you're going on doing a surgery. So what can happen? You are missing the uterine pedicle. So bleeding can occur. Right? So what is that bleeding called? Hemorrhage. Hemorrhage can occur. Then hemorrhage, what are different types of hemorrhages? Yes. Primary, secondary and reactionary. Very good. So what is primary, secondary and reactionary?
Primary is etiology. Etiology is unknown. Intraoperative. Secondary is post-operative.
When?
After 24 hours.
Okay. Reactionary? the patient, you've done a surgery, you've shifted the patient to post-op ward, then over 5-6 hours later, an intern goes and says she's got tachycardia and there's some bleeding from the wall. That's reactionary, 5-6 hours later. Okay? So primary is the time of the surgery, reactionary a bit later, and then secondary 24 hours later. So hemorrhage can occur. That is one immediately, short term. Anything else? You can clamp or you can make a rent in the bladder rent. Or you can catch because the uterus has come down, there's kinking of the ureter with the bladder also has come down. So you can catch the ureters also, ureteric injury, a fistula can occur, all those things. Anything else? You can damage the intestines when are coming out through the POG. Intestinal injury can occur. So all those injuries can occur intraop. Yes? Then after that, if you have caught the ureters or you have unnoticed, not noticed the bladder injury, she can come up with leaks 4 days later. 4 days later after the surgery, leak, urinary leak.
Incontinence.
Yeah? Incontinence. That is, what is true incontinence? What is true incontinence? All these fistulas, no, they keep on letting out urine. Not like stress in urinary. It's true, right? So after 4 days only it will be evident if it's a bladder rent or something. So they'll come with urinary leak or this fistulas, all those things can late complications. Or if the vaginal cuff is infected, cuff cellulitis, breakdown of the cuff so that the vault can open, the intestines can come out. There are late complications. And anything else? Late long term will be vault prolapse. Okay, all these things are complications of prolapse surgery. So having done this with, suppose a patient, now the same patient, she has medical comorbidities, she is unfit for surgery. What will you do?
We can do Leafold's colpoplisis.
You can do itself. When you go for a treatment, I said all those 4 things has to be taken into account.
Age.
Yeah. So this patient, unfit for surgery, what will you do?
We can do 2 things, ma'am. One is we can do pessary insertion, ma'am.
Yeah.
And then another day we can do is by applying local anesthesia, we can approximate the anterior and posterior vaginal walls.
So you can get the consent, the wishes of the patient. Every time you tell about the treatment, you need to get the wishes of the patient. Consent. What is her wish? We are not supposed to do what we know or what we like. We want to do what the patient says. It's a cafeteria approach. You have to tell what are the treatment options available and you choose and tell me. And you need to tell the pros and cons for each treatment, right? So this patient, definitely we can go for a major surgery because she's unfit. The 2 options will be pessary and colpoclysis. What she says is, colpo means vagina because you approximate the vagina, push the prolapse up and approximate the vagina, it closes the vagina. That is colpoclysis. There are total colpoclysis and partial, right? Partial is Leafold's. What we do is you denude, take a square or rectangular piece of vaginal epithelium from the anterior vaginal wall and from the posterior vaginal wall, then push the prolapse and approximate these 2. So the prolapse will not come out, the vagina is occluded. One disadvantage is she would not have sexual functions. Another disadvantage is she's got the cervix within her. If there is any carcinoma developing, it will be difficult for us to visualize because the vagina is approximate. But she can put out all her vaginal secretions, cervical secretions to the other areas because only the anterior and posterior vaginal walls are approximated. The lateral walls are not approximated. The fluid can emanate through the lateral sides. With that only you will be able to pick up whether she's got a CA developing or not. What is total colpoclysis? The whole vagina is a head-shaped structure. No? The whole vagina is by a purse string suture you occlude. That is colpoclysis. So that is one thing. And pessary, the indication for pessary in prolapse.
In prolapse, we can do an early pregnancy, ma'am.
Pregnancy with prolapse.
Prolapse pregnancy.
That is indicated for a prolapse. What pessary you will put?
Ring pessary.
Ring pessary. Okay. So what are the other indications for pessary?
Puparium age.
Immediately after delivery, if she has a prolapse, you need to put pessary. Then
Patients who are unfit for surgery.
unfit for surgery.
And who are having comorbidities.
Comorbidities, you would put what is the pessary care that you must be giving? How do you give?
We should follow up every 3 to 6 months.
Every 3 months she has to come for follow-up.
Sterile.
You have to take it, sterilize it and reinsert it. Then you have to give the approximate size of the pessary. Okay? Yeah, that is the pessary. Suppose a young woman comes with prolapse. What's your management?
If we should ask her if she has completed her family or not, and if she wants to retain her uterus or not, if she wants to retain her menstrual cycles or not, then we can, if she wants to retain her reproductive functions, we can do sling surgeries, ma'am. There are three sling surgeries: Kanas, and then Purandas and Shirokar surgery.
Kanas, Purandares and Shirokar. A young woman with prolapse, she wants to retain the uterus for menstrual function. So she wants to retain the uterus for fertility. You need to preserve the organ. So you have to put a sling. Sling means what? You put it and attach the sling, attach it to the uterus and pull it up and keep. Pull it up so that it doesn't prolapse outside. It stays there. Okay? But if you have done a sling surgery, then delivery should be by C-sections. You're not going to allow for a vaginal delivery. Okay? That is one thing. And there are different types of sling you can go. If you are using a biological, the own rectus sheath that is called Purandare cervicopexy, the others are muslin tape and you can use other non-absorbable sutures. There are different Shirokars. You attach the cervix to the sacral promontory. Or Kannas, you can attach it through via the ASIS and go up. So the different types of surgeries. And what is called a dynamic sling?
Dynamic sling is when we attach it to the rectus sheath, ma'am. Rectus sheath, it is dynamic sling.
Why? So when you use a biological material, it's going to give way. When the patient is straining, it will go down, stretch, come up. It's dynamic. But when you use a synthetic tape, allocated length only will be there. It won't be pliable. It won't go down and come. It's not a dynamic sling. Dynamic is always when you do it with a biological. So Purandares will be a dynamic splint. Other synthetic tapes are not dynamic. And depends upon how you catch the uterus and pull it up and keep. If you attach the sling to the anterior part of the cervix, or if you attach the sling to the posterior part of the cervix and pull it up and keep it to the bony peritoneum hub, what happens? Suppose, can I give you an example? Like I'm putting an artificial tape, muslin tape, and attaching it to the anterior part of the cervix, pulling it up and keeping it to the rectus sheath or the sacral promontory. What happens when you pull?
Prolapse will be...
What happens?
Stretching.
What is anteversion, anteflexion? What happens? You pull the cervix up. So the posterior compartment is wide open, right? So enterocele is more common if you attach. Hope you understood.
Okay, ma'am.
So when you catch it to the anterior part of the cervix and then pull, the posterior, it pulls the uterus up like this. The posterior is open, so enterocele can occur. So all these are different. And suppose you have a young woman with a prolapse, first degree or a second degree, and she's got one child. What surgery will you do? Manchester. What is Manchester or Fothergill surgery? First degree or second degree uterine prolapse?
Cervical amputation.
So what happens in young woman is that she is in her peak of her hormones. She has a lot of estrogen within her. So what happens, even there is some faulty technique in the previous delivery and she has strained over and there is stretching or the pudendal nerves have damage, the uterus tries to come out. But what happens, her estrogen will not allow it. The supports of the uterus will try to pull it up. So what happens, where are the Dillon C1 supports are attached? They are attached to the
cervix.
At the internal os and at the level of the fornix and the cervix. They'll try to pull the uterus up because, but there are some weakness that is trying to pull it down. So traction counter traction occurs. What happens? The cervix gets elongated. So the total cervical length will get elongated in young women with prolapse, even though they have a first degree or a second degree prolapse. So how will you measure the total cervical length? It is from the external os to the internal os. When you pass a sound, the distance covered by the external os to the internal os is the total cervical length. And when you minus it from the phonics, you put in another sound and measure the posterior phonics length and minus it, you'll get the supravaginal elongation. Whatever you see down in the vagina is the cervix, which is below the vagina. Infravaginal cervix. Purida. So some amount of cervix will be above the vagina. That is supravaginal cervix. So now in this young woman with prolapse, the supravaginal elongation of cervix will be there, which you can't see from down. So when you measure the total length of the cervix from the external os to the internal os and subtract it from the infravaginal part, you will get the supravaginal length of the cervix. What is the normal length of the cervix?
4 centimeters.
4 centimeters. If it's more than that, 4 will be in pregnancy. In gynec, at least 2.5. So when these young women with the total cervical length, which is more, then you can find out that there is some supravaginal elongation of cervix. So then that is the time that you can amputate the cervix, where you can do this Fojagals. It is just not only amputation of cervix. You can total cervical length you can make into 2 or 2.5. Rest of the length of the cervix you can cut. Then what you will do is the supports of the Mackenrods, the lateral support, which attaches the cervix to the lateral pelvic wall. That you will dissect, cut it, and plicate it anterior to the cervix so that it pulls the uterus up. Right? So Fothergills is nothing but you measure the total cervical length, extra cervix you're going to amputate. You're going to plicate the Mackenrods to the anterior lip of the cervix and formation of the cervical lip. You can just tell not much. It is for young women with first degree or second degree who are desirous of pregnancy, and you can do that. Before they were doing combining Shirodkars with family planning, PS. They can go through the POD and do a puerperal sterilization also, but now it's not being done. Not supposed to do. Family planning procedures should not be combined with other procedures. Okay, that is with Shirodkars. Okay, any other surgeries?
Shirodkar modification of Fothergill surgery.
Okay, okay. So for suppose a young girl comes with congenital prolapse. What is congenital prolapse?
From birth onwards.
It is due to the collagen deficiency.
Collagen deficiency, or usually young girls with congenital prolapse, it is only the infravaginal part of the cervix which will be elongated. There will be no uterine prolapse. So the cervix length will be around 6 or more than that. So for them, you can just amputate the cervix and leave congenital. There is no support defect if it is only infravaginal elongation of cervix. Yeah. Anything else, ma'am? So for this patient, you're going to do after consent, you're going to do Bodmeyer's vaginal hysterectomy with anterior colporrhaphy and posterior colpoperineal and if it's an enterocele, you will combine with McCall's scaldoplasty and then monitor her. So the advice is immediately after surgery, you will put in a pre-op is after surgery, you're going to do catheterization, monitor the vitals, antibiotics. Okay, you can remove the catheter after second post-op day, and then vault care, discharge her on 8th post-op day.
For 24 hours.
Yeah, pack can be kept, and then tell her to come for review later. Okay. We'll finish?
Yes.
Thank you. Thank you. Thank you, ma'am. Thank you. Thank you, Trisha, and thank you. I didn't get your name. Sridhar. Thank you.
Thank you,
so
ma'am.
much. Thank you. Okay. That's all, ma'am. Thank you, students. Hope konjamaadu புரிஞ்சுதான் தெரியல. I don't know. வேண்டாம். Okay. Thank you. வேண்டாம் போலாம்